And thank you very much for the invitation to come here and talk about this exciting subject. It took me on some paths that I had no idea that I was going to go down. So I'm going to talk a little bit about these biomarkers to assess the risk of comorbidities. We've already heard a lot about biomarkers, about different proteins to measure, and I think we've had some wonderful talks until now. These are my conflicts of interest, and I'm going to go straight onto this because I wanted to check out what really is the definition of a biomarker, because we have been talking about biomarker for quite a long time. And I found this definition from the National Institute of Environmental Health Sciences. And what it says is that a biomarker is an objective measure that captures what's happening in a cell or an organism at a given moment. Now, this really opens up for a huge bunch of things that we can measure, right? It's just an objective measure, but it is an objective measure. And so where can we find these biomarkers going down on this? Well, we've talked a lot about this until now, and this is really the classical biomarkers that we find, genes, proteins, lipids. We can measure the microbiome, what goes up, what comes down, and there's a lot of other molecules that we can measure from serum, from skin, and so on. We can also do imaging. We can do CT scans. We can do DEXA scans if we want to look, for example, for osteoporosis. The risk of osteoporosis is something that we get out of the C-score and the T-score from a DEXA scan, right? We can also do physical measurements. We can measure blood pressure. This tells you something about the risk of developing cardiovascular events. We can do spirometry to tell you something about the risk of developing asthma. We can do patch tests for contact allergies. Maybe not a biomarker, but it's at least a diagnostic marker. We can also do functional tests like exercise tests. We can do a glucose test to test you for diabetes, to tell you something about whether you have a risk for developing or if you have a latent diabetes. And this is also something that we talk about when we talk about comorbidities. We can do PROs. This is an objective measurement. It's really a subjective one that you get from the patient, but it's something that we use. We can ask the patients how they feel, how the treatment is working. And finally, and this is the latest, and now I'm really going out on a limb, we can do digital biomarkers. We can look at wearables. We can get data from, like a watch like this. We can look at pulse. We can look at movement. We can do voice analysis to check if patients are getting depressed. There's a lot of things here. We can look at online activity from the patients. So there's a lot of biomarkers that we can start out with. So 20 minutes is not really enough. We've also talked a little bit about this. Diagnostic biomarkers, right? Which disease are we talking about? Like serum ACE and sarcoidosis. We can talk about prognostic. This is something that we've just heard about, something that we're really, really interested in. The outcome of the disease or the severity of a disease, and in this case, what comorbidities are the risk of, and are the patient in a high risk of developing comorbidities. And finally, also the response to treatment, which I find is very, very interesting. And we are, in my opinion, as we just heard, at a good starting point, but we are not there yet. So in terms of atopic dermatitis, diagnostic, clinical diagnosis, we can do biopsies and we can do a support from serum IgE. Prognostic is the risk of asthma, contact dermatitis, food allergy, and cardiovascular disease. And finally, also the response to treatment with the JAKs and the biologics and nutritional treatment. As we've just heard, it would be great also in AD if we could do a blood test when they came through the door and say, well, you need to go straight to this treatment rather than trying out a lot of different treatments before we find the right one. But what are the comorbidities in atopic dermatitis? I tried to just put them up here, and we're going to discuss some of them. We have the typical type 2 inflammatory diseases that we see together with AD, like asthma, hay fever, food allergies. Then there's the cardiovascular diseases. I know that this is a matter of debate. I don't think there's any doubt that there is an increased risk of cardiovascular diseases in this patient group, but whether it's due to the atopic dermatitis itself or it's due to the lifestyle, that's a whole other discussion and not one we're going to have here. Then we have psychiatric diseases. We know there's an increased risk of psychiatric diseases in this patient group, but whether it's due to the fact that they're more stigmatized, that they have less social activity, or if it's due to the ongoing inflammation is also a question that still remains to be answered. Contact dermatitis, an infection, and also, again, maybe taking it a little far, the social and educational life of these patients is also something that's affected by the disease and may be counted as, a comorbidity. Now, these are some studies, and I've called it a simple approach to biomarkers in AD, and I'm aware of that. But we wrote the study ourselves, so it's okay that I call it simple. But it's a little bit old, and what you can see here is that we looked at this group together with the group in Kiel, and we looked at 4 different alarmins, and we looked at IgE between, healthy controls and AD in children and in adults, and we also compared the children with the adults. Down here you can see this is really very simple. This is some of the things that we heard also. It's just one cytokine, and we can see whether it's increased or decreased in these groups. But we also tried to relate it to comorbidities and to look at whether they had allergic rhinitis, allergic asthma, if they had sensitization to dietary allergens or even to inhalant allergens. As you can see, it's a bit here and there. We did Bonferroni correction, and we can find a few of them. But what you also see is that quite a large standard deviation. So whether it's diagnostic or not, maybe not, but it's really it's a clue to go for. If you look down here, you can see, for example, here with the inhalant allergens, it's quite increased in the group. If we look at the total number of AD patients, the serum concentration is quite increased here compared to the healthy controls, but not as you can use it for a diagnostic mean. We just heard about all the validation that we need in order to use them like this. And then there are other studies too, like you can have the toll-like receptor mutation together with IgE is associated with asthma, allergic rhinoconjunctivitis, high eosinophils and food allergy, ST2 and IL-33 together with bronchial asthma, cardiovascular disease, IL-23 may. But you see the code word here is may and can be and correlation and perhaps. So it's not really something that we can, it's not a 0 or 1 response that we have here if we just take these ones. And then I'm very happy that Marjolein showed the initial study, because I'll take the number 2 study because this is the figure that shows the same thing. And it's really a very, very impressive study measuring all of these proteins in the blood and having these 4 clusters. I don't remember if it was 130 or 150 different proteins that you measured. It's really amazing. And here you can also see that the clusters that you mentioned, that there is a difference between some of the comorbidities, maybe not a lot, but still some. You can see that cluster B, for example, has a higher risk of, can you see the pointer? Yes, you can. Higher risk of asthma compared to cluster C. And down here you have the rhinitis. So there is some differences in these clusters, also with regard to comorbidities. So we are on the right track, right? But there's still a lot of overlap between the clusters and the comorbidities. Then we have the sleep disorders and poor quality of sleep, because we know that AD patients, they don't sleep well. They have longer latency of sleep. That means that it takes longer for them to fall asleep. They have an increased fragmentation of their sleep. They have difficulties in waking up, so they get a poor efficiency out of sleep. Maybe that's not a nice thing to say about sleep, but it really means that you don't get rested. And we know that this is high risk for ADHD, for obesity, for hypertension. So suddenly we're talking about this is a risk factor for both psychiatric disease, but also for cardiovascular disease. And how can we measure this? Do we have something to measure this kind of sleep quality with? And there's been several different ways to do this. There are PROs. There's an overview here of the different kind of PROs, questionnaires, because we really need to ask the patients with PROs. These are validated. I can tell you something about the quality of sleep. I'm not aware of any studies that takes these PROs and correlates them to the risk of psychiatric disease or cardiovascular diseases in AD patients. You can also do the wearables, right? Like this, just a simple sports watch. You can get it for less than, 50 euros in any sports shop. They're very popular, and they can tell you something about both sleep quality but also movement. But you can also do something with a mattress or something called ballistocardiography. Yeah. I'm not sure that I would wear or even sleep with one of these, but it tells you something about the respiratory movements, but also the ECG, and it's something that tells you something about the sleep quality of the patients. Then you can also do the CT scans, and this is also a study that we did in our group some years ago, and what we really did was that we did CT scans of the coronary arteries. So simply enough, we looked for atherosclerosis, and we separated the coronary arteries into 18 different segments and looked at how much atherosclerosis did they have. And what we found was that if you look here, you can see that among AD patients, there was an increased degree of atherosclerosis as counted by the segments that were involved with atherosclerosis in these patients. When they had mild atherosclerosis and moderate atherosclerosis and compared to psoriasis, where psoriasis had the very severe atherosclerosis. And not that I'm going to show you, but this is really a biomarker for the risk of developing cardiovascular diseases in these patients. Again, we didn't have any data on whether they smoked or not, whether this was due to the disease itself, but it told you something about the risk of having cardiovascular events. Finally, the digital biomarkers. There's some work here from Alexander Sink's group, and I would like to, this is not AD, but this is looking at pollen in Germany and Sweden. And up here, you can see in the first graph in A, this is pollen over Germany, and down here in C, it's pollen in Sweden. What you can see here is crowdsourcing, where you go out and you ask Google how many has searched on terms related to asthma on Google in Germany at this point in time, and how many in Sweden. And as you can see, it completely follows pollen season, you know, the real pollen numbers. So it's really something that we can use to detect things that takes place in real life when you do this kind of crowdsourcing. And they did this in AD, where they looked at social media. This is a French study where they went in and looked with text analysis on what was written. I know I'm a little bit out in biomarkers, but it's still a marker. It's something that we can measure objectively, right? And they looked at it, and they could look at controlled AD and uncontrolled AD, and they could see that there were specific words being used in these texts on the social media, depending on whether you controlled your atopic dermatitis or not. And again, also here, you can see search terms on Google. This is again from Alexander Sink's groups, looking in Germany. And what you can see down here is that if you look at comorbidities, there is an increased search here, and this is the number of searches over time. So it does not tell us anything on the individual patient plan, but it tells us something that there is a gap in perhaps our treatment or perhaps our information of these patients in telling them about the risk of disease. But I think it's something that's still in its birth, but it's something that we're going to use a lot more over time, these kind of analyses of what takes place in the digital life. So in conclusion, I think we just heard about the diagnostic biomarkers, but maybe we need some more reliable prognostic and predictive biomarkers. And now you even destroyed TARC, right? So we need something new there. We have a lot of associations with different kind of things, but we need a combination of these. And I think the Dutch study is really showing this is the way forward, but maybe we need to combine it with other things too, like digital behavior, like spirometry, like DEXA scans, in order to tell us something about the comorbidities. And finally, you know, I think digital biomarkers, maybe that's a bit far-fetched, but I told you it took me down a road where I didn't know I was going. Digital biomarkers could be a path to predicting disease severity. So with that, thank you very much for the invitation to come here and speak.
We have time for some questions. Well, I got one for you. So I found it to be very informative. So there's a lot of things that we can measure and kind of collect information on. But at the same time, the more we measure, the more it's going to affect the overall power of what we can do. You need progressively bigger sample size as the more things you're kind of measuring. How should we go about identifying which biomarkers we actually want to measure and which ones should we prioritize on?
I think this is really a very good question, because now I just put a lot of things to the table, right, that we can measure this or that. I think that we are actually doing it the right way, because like we're meeting here and we're discussing, you know, could you use a wearable to maybe measure sleep quality, And if this turns out to be positive, then it's something that we might want to use together with the results like the ones from Holland. So we have to take it step by step, you know, bite by bite. So it's really difficult to maneuver in this one. But on the other hand, the power that we get now to data process, right? It's growing exponentially. So I think that within a few years we'll get more and more data, and we'll do all of these kind of machine learning, whatever it is, to learn these kind of things. So maybe the problem is solving itself.
Okay.
Nick Reynolds, just to add to the debate, I mean, I think one thing we haven't discussed actually is that I think in clinical practice, atopic eczema is much more variable day to day than psoriasis, and patients report that. And Maiko Tanaka from Imperial in London has done a nice study where she's got patients to report daily their symptom score on an app, and has used the pattern of development of those symptoms to predict outcome a few days away. But you know, you're picking up flares early,
Yeah.
and maybe we have to go back to basics and think about, because I think that happens even when people are on dupilumab, doesn't it? They still go along with little flares. So I think thinking about it as a continuous variable with easy measurements may be a very good way. You know.
I agree. It could be like an app or a PRO combined with something in how you sleep, measure your sleep quality, which could then predict, do I need to intensify topical therapy for the next couple of days? I agree completely. Yeah.
Great. Well, thank you.